Welcome to the St. Francis CME podcast. I am Brandon Kitchens, podiatrist at Tulsa Bone and Joint. I have no disclosures. This episode has been approved by the St. Francis Hospital System CME program for AMA PRA Category 1 credits. See description for details. Today's topic is the crooked foundation, why hindfoot varus and cavus feet cause chronic ankle problems. Based after the podcast, we should be able to recognize the biomechanical features of cavovarus, hindfoot varus. Basically, that means a high arch deformity. We should be able to explain how this alignment predisposes patients to recurrent ankle sprains and chronic instability. We should be able to perform a focused diagnostic exam, which includes the infamous Coleman block test, and formulate a conservative and surgical treatment plan based on the deformity for our patient and their symptoms. I like to start out with a case study. So let's start with the case that the ankle that won't heal. Let's say we got a 19-year-old soccer player who presents with his fourth ankle sprain in 2 years. He has lateral ankle instability, peroneal tendon pain, a high arch, and he's got a callus underneath his forefoot now, and his hindfoot is in varus on a standing exam. He's completed physical therapy in the past, he's also been braced, and he still complains of pain. And he also has still sprained his ankle. So the question is not, why does he keep spraining his ankle? The question should be, what's wrong with his foundation? So, question, the pathogenesis. Why does this cause instability? Well, if we really kind of break it down biomechanically, cavovarus deformity basically means that the foot is slightly inverted, supinated, and it's a high arch. That is basically a recipe for disaster. What happens is with this elevated medial longitudinal arch, the inside part of your arch, it's tilted inward, and oftentimes that first ray that goes to the big toe is plantar flex down, and this causes the deformity to be driven. In normal gait, the heel should strike in slight varus, and then evert as it absorbs the shock. In a high arch patient, the heel is going to remain in varus and inverted. This is going to cause for lateral column overloading. This is going to cause strain to the peroneal tendons on the outside of the ankle, and this is also going to stretch out your ligaments that are probably already chronically damaged. So the evidence behind this is recurrent ankle instability is strongly associated with hindfoot varus alignment. There are several studies that will support this. Up to 67% of patients with chronic lateral ankle instability are going to demonstrate this subtle cavovarus deformity, right? Cavovarus alignment increases that lateral ankle ligament strain and the momentum of inversion with activity. It's this nasty cascade. So, number one, you have the recurrent lateral ankle sprain, okay? Number two, it becomes chronically attenuated, that anterior talofibular ligament, that calcaneofibular ligament, getting worn down. Then you have the peroneal tendon overuse, and that can cause for tearing and swelling. And then you'll have lateral ankle impingement. And then you have possible osteochondral lesions of the talus. My goodness, what's after that? Well, you could have end-stage arthritis of the ankle, right? You can see the nasty cascade of events if we don't catch it soon enough for these patients. And oftentimes it's right underneath our noses. We call this a progressive mechanical disease. So what should we look for, right? Not everybody's looking at feet all day like I am. So if patients are complaining of an ankle sprain, good questions to ask is, how many ankle sprains have you had? Is this a first bad one? Do you get them often? Have them stand. Look at them stand. Do they have a hindfoot that's in varus? Do they have a high arch? Do they have calluses on the bottom of their feet? There's a really fun clinical exam. It's called the peekaboo sign. Basically, this means that you can see the inside of their heel going peekaboo. Another really fun test is something called the Coleman block test. This is where you get that textbooks that you haven't read in 15 years. It's got dust on it, and you have them stand on it. How you have them stand on it is you place the lateral forefoot on your textbook. You could also use a block. But if the heel corrects, that tells us that it's a forefoot-driven cavus. If the heel remains in varus, we have a hindfoot-driven cavus. Sometimes we can also have global cavus, but for today's podcast, we'll kind of leave that for another time. These tests are important for if the patient's not getting any better with conservative options, because they're really going to guide surgical planning purposes. This is when you send the referral to your foot and ankle specialist, and they'll applaud you for attempting to do this to help give them an idea that they know what to expect. Other important modalities is getting a weight-bearing x-ray if you can. Realize that non-weight-bearing imaging is great for trauma, but it's not great to understand the biomechanics. It's just a loose bag of bones floating in the air. Okay? What I'm looking for with these types of patients is increased calcaneal pitch, Meary's angle, a plantar flexed first ray. They're going to give me a lot of information. Am I dealing with arthritis within these patients because they've just been wearing down their joints? It's essential for accurate deformity assessment. Other things to think about: neurological causes, right? Are we dealing with Charcot-Marie tooth disease? Am I dealing with a spinal cord pathology? Or am I dealing with a patient that had a stroke? Oftentimes, cavus foot is a neurological condition until proven otherwise. That being said, conservative options are still the first mainstay, right? Our goal of this is to shift the weight. We want to reduce the inversion momentum. We want to protect the lateral ligaments, and as well as those tendons on the outside of the ankle. Bracing and orthotics are usually great options for this conservatively. Things that we can do that you may be wondering is we can add a lateral wedge removal, first ray recess, lateral heel post, arch support that doesn't overcorrect. It's not jamming into their arch. Boy, oh boy, I've seen a lot about orthotics, and the reason is because they try to make the arch too high. There are certain lace-up braces that help too. Semi-rigid AFOs are all really good options to help with your patient to stay ambulatory and independent. Sometimes the patient needs rehab too. We need peroneal strengthening. We need proprioception retraining, balance retraining. That's where a physical therapist can be really good at helping their patients get back, because these neuromuscular rehabs are going to reduce the recurrence of that ankle sprain in the future. If all those things fail, well, that's where surgery comes into play. Surgery is not just correcting the ligaments. I think I would be doing a disservice to my patient by just tightening up their ligaments and not addressing the cause. The effect now is the ankle instability. The key principle here that I want you to take away is that cavo varus is not corrected with ligamentous repair alone. Okay, that may help them for a year, but then they're right back to square one. Procedures that need to be included may be a lateral calcaneal osteotomy to correct the varus. Maybe I've got to dorsiflex the first ray. Maybe I do need to repair the ligaments, but on top of maybe doing a tenodesis with the peroneal tendons to help strengthen them to work together better. Oftentimes for my patients that are a bit older and that have arthritis, maybe I'm looking at a fusion, and that's sometimes a hard conversation to have to your patient to tell them, hey, you're going to lose some movement. But that being said, patients undergoing cavo varus reconstruction show significant improvement in AOFAS scores and reduction in recurrent instability. So it's important to educate your patient that they can do better, right? Not that it's a hope and a prayer, okay? Combined deformity correction improves long-term stability compared to ligament repair alone. That's the key here. The goal of what we're trying to obtain with this is to basically correct not only the foot deformity, but to prevent these recurrent ankle sprains, to have them be independent, to have them be active, especially if it's a younger patient. Look at the heel. The deformity is often subtle, but it's powerful. You cannot stabilize a crooked foundation with stronger ligaments alone. That completes today's episode. Please follow the link in the description to complete the evaluation that's required to claim your AMA PRA Category 1 credits. Thank you for listening to the St. Francis CME podcast.